It's Raief. Killeny is a pharmacist and pharmacy owner, Total Health Pharmacy in Burlington. I did notice on Raief's profile on LinkedIn that he spent a couple years in Paradise, but he decided to come to the real Paradise, which is Niagara instead. So let's give him a big warm Niagara round of applause.
Good evening, colleagues, and thank you so much all for being here today. A special thanks for Nishan and Sean who organized this meeting. We really appreciate the opportunity to talk to you about local anesthetic. As a pharmacist, we're always looking for ways to make treatment more comfortable and effective. One area we often deal with is managing pain, especially in procedures like blood draws, injection, or minor skin treatment. Today, I will be talking about EMLA cream, a topical anesthetic that can play a big role in reducing pain in this situation. We'll cover how it works, when to use it, and a few tactics or tips to use the medication to get the best result out of it. Let's get started. Is the green one is the one I'm supposed to press? Okay. My presentation today consists of 3 different sections. The first section, what's EMLA and how does it work? Section 2, the properties of EMLA and the rationale beyond using local anesthetic in the skin procedure. Section number 3, which is the dose of an administration of EMLA, contraindication used during lactation and pregnancies. Excuse me, can we make the screen bigger? Yes, thank you. The first section, we will talk about EMLA. Before we talk about EMLA, how it works, what's EMLA, we have to understand how does it work, the local anesthetic, or what make an effective local anesthetic works. The local anesthetic, to be effective, it has to penetrate the skin. To penetrate the skin, it has to have 2 different properties. It has to have a high water content, and also all the constituent of the mixture has to be in their basic pH, meaning the pH has to be high enough to penetrate the skin. In this case, if we achieve both of them, the medication will be effective in penetrating the skin, which it will work. But unfortunately, most local anesthetic are poor in penetrating the skin, and that's due to lacking either one of these properties, either not a high water content or it's not in their pH. And why is that? Because lidocaine or local anesthetic is soluble in acidic form, and it's insoluble in basic form. That's why the pH is low, so it will be very poor penetrating the skin. In this case, the medication will be weak. And that's where they develop EMLA to overcome the problem of both issues. EMLA was developed as made from a mixture of lidocaine and ipralucine, as you all know. It's dissolved in water, which gives you the suspension form. That's a high water content. But at the meantime, also they added the sodium hydroxide to keep the pH high enough to keep all the majority of the prelucine and lidocaine in their basic form. So we achieve both properties, which in this case will be effective in penetrating the skin. In my opinion, this is the most important slide because that will differentiate EMLA between any other local anesthetic. EMLA, it's a combination between prelucine and lidocaine, and the combination not only because we added 2 different ingredients to make it more effective, but also I will explain to you the next slide what is the benefit of mixing these 2 ingredients together. There is 2 pain protector on one, which is a prelucine and lidocaine mixed together in eutectic mixture 1:1. We all are pharmacists, so we know what eutectic mixture is, but just a reminder, when you mix 2 different ingredients, each one of them has a specific melting point. The eutectic mixture has a lower melting point compared to each one of them. I will explain this in the next slide, but that's how they come up with the name EMLA, which is the first letter of each word, eutectic mixture of local anesthetic. As I mentioned before, the lidocaine melting point 67 degrees. And for prelucine, the melting point is 37 degrees. When we mix both of them together, the oily mixture or the cream melting point will be 18 degrees, which will be one of the key important elements here to allow EMLA to penetrate the skin, because as soon as it touches the skin, which is the normal body temperature, 37 or 36.5, it will melt and will be easily penetrate the skin. Also, adding the surfactant in EMLA modify both of them, the lidocaine and the prelucine interaction, creating a nanoparticles of EMLA, and the nanoparticle, that's a very small particle, will be easy to penetrate the skin. So as soon as it touches the skin, it melts due to the lower melting point, and also it's a small particle using the surfactant. So EMLA become micellar liquid in contact with the skin, so easily penetrate the skin and provide its action. This is the main idea behind producing IMLA compared to lidocaine by itself or between any other local anesthetic too. It resolves the issue of penetrating the skin. Indication and use of IMLA, the indication and rationale behind using this IMLA in this indication. Both of them, either the cream or the patches, as you all, it's the same. Patches are IMLA cream, but pre-measured dose. So we can use it as a topical anesthesia for intact skin, not skin cut except leg ulcer, which we'll explain this later. Prior to needle insertion like IV catheter or any blood sampling, any kind of injection, which we all know about this, any kind of vaccines. Also, IMLA cream can be used as a superficial surgical procedure if it's less than 10 minutes, something you apply right before the procedure, it numbs the skin. As a topical anesthesia in the genital mucosa. Genital mucosa is a very sensitive area, which we all know will be very, very painful, whether it's examination or any kind of procedure to be done. So we need to numb the area before the physician can perform the process. Also, prior to infiltration of anesthesia, in the genital mucosa, sometimes the physician has to inject local anesthetic to give more effect, but they consider also applying IMLA before the injection to numb the area so the patient does not feel the pain of the injection. Or we can use it alone in surgical procedure lasting less than 10 minutes as well. We can also use topical anesthesia or IMLA before leg debridement of the leg ulcer. When they clean the leg ulcer, which is very, very common in diabetic patient, they use IMLA cream to numb the area so the doctor can perform the procedure faster and easier, and the patient does not need to stop the physician from performing the job. The rationale for using topical anesthesia or IMLA in reducing pain in vaccination. 12 billion vaccine injections are given each year. Long after the currently painful sensation is gone, the emotional sequelae surrounding the experience can linger, and that's where it leads to phobia, and the children or even young adults will be scared to see the physician because they know this is the office, I'm going to get a shot, it's painful sensation. Untreated pain may increase the fear, which in turn may increase the pain in future procedure, which is the phobia, that's what we talked about. So pain mitigation is considered part of good vaccination clinical practical by the WHO organization. Local anesthetic before vaccination reduce acute distress for injection pain and also does not affect the immune response at all. The pain cushion problem. According to the WHO, the younger children require about 10 vaccines, and especially in the first couple of years. So that's a lot of injection for a young kid. So applying the local anesthetic will help the patient, will help the child. 93% of toddlers shows signs of serious severe distress or panic during vaccination. They move rapidly and irregularly, moving away from the doctor, affect also the relationship between the physician or the healthcare professional and the child, which cause trauma for kids when they become young adults as well. Children learn that vaccine can hurt, so anxiety or hypersensitivity at future pain may occur or develop, so they develop this idea in their mind. When I see the physician, they will give me a shot, it's painful. So they start crying even before they enter the facility. Also, needle fear can lead to avoidance of appropriate medical care. I have seen young adults also refuse to perform either a blood work or some simple procedure because they are afraid of needle. They are needle phobic as well. Topical anesthetic are recommended to reduce pain during vaccination, especially for younger infant who cannot advocate for themselves. We do not really have to wait until the patients say that I need local anesthetic. They are young kids. They can't say anything except crying. So if we apply this ahead of time, I think that will prevent the pain and will avoid the consequences happen after. This is not all a hypothesis. That has been many clinical trials has been done to compare the vaccination using IMLA or local anesthetic versus placebo, and it's always statistically significant, shows that IMLA reducing the pain was 16% versus 32% if you compare placebo to IMLA, which was statistically significant. They use the visual analog scale as a pain scale, so it's not really something like a hypothesis. They actually measure the pain using a ruler and the visual analog scale. Also, using IMLA as a topical anesthetic before the vaccine lead to fewer children can cry using or to the extent they breath hold themselves as well, versus placebo, 7.5% was IMLA versus 22% placebo. So the extent of the time of crying and the pain itself from the injection was much less with IMLA. There is also rationale for using topical anesthesia to reduce pain in surgical procedure like Botox. Botox is very simple procedure, has been done many times now. Everybody is familiar. but it's a lot of injection done in the forehead area. Injection around the forehead and eyes causes more sensitivity and anxiety than other body area because it's very sensitive, and imagine you will get like maybe 20 shots or something in your forehead. It's a painful, even the idea itself, not the physical pain itself, it's painful. Although Botox injection is simple and fast-acting procedure, some patients refuse to have the repeated injection due to the pain associated with the injection itself. Also, if we will use a local anesthetic as an injection or infiltration, that's also painful as well. So the physician chooses to apply IMLA before they even infiltrate the local anesthetic before they inject Botox. Epilation, which described that the patient has unpleasant or painful sensation. Also, infiltration of local anesthetic before the epilation is painful and causes some pain. So applying IMLA cream or local anesthetic will reduce this kind of pain. Laser therapy, the most effective treatment in port wine stains. However, it's a very painful sensation too. Most of these patients are kids or young adults, so applying IMLA also will reduce the pain associated with the laser therapy, which facilitate the process. Let the patient also go for the second or third or fourth visit. Otherwise, the patient will quit after the first visit because it's a very painful sensation as well. There is also a clinical study has been done. In this case, the study IMLA was applied 30 minutes before the Botox injection using a spot application, meaning that they apply only to the spots where it will be injected. IMLA was effective in improving discomfort of Botox injection. Applying IMLA was easy, convenient, and also inexpensive, as one 5-gram tube will be sufficient for about 25 patients because they use a spot technique, just a small amount only. Occlusion was not shown to be necessarily in this case. You don't have to apply any occlusion because it's not going to go anywhere. Ice was inconvenient to apply, and pain control was only partial effect, was not very effective. Other topical anesthetic, none has clearly demonstrated pain control superior to IMLA at all. In another clinical study, it has been done over 40 patients. Each had 3 to 5 preocular injection above the eye, which is a painful spot as well. IMLA significantly decreased the pain of Botox injection. Also, IMLA increased the patient comfort, and the average pain score using IMLA was 3.25 versus 5.83 with a control side. More patients prefer IMLA cream over ice because it's less messy and give them more pain control. No side effect was reported with IMLA whatsoever. In another clinical study has been done for patients going through the epilation process, and also in this case, they took the assessment with the patient using the visual analog scale. They also assessed the cosmetologist or the doctor or the practitioner himself or herself, and both of them, the result was very similar. Among where 0 shows here that no pain, and 3 is the most painful sensation. Most patients on the placebo shows 3, which is the highest pain, and people on IMLA shows 1 or 2, which is less pain or mild to moderate pain. The treatment was also here in this study. After treatment with IMLA, patient experienced significantly less pain compared to placebo. 90% of patients rated IMLA as less painful than placebo. So IMLA was, in this case, was easy to apply and also relieved the pain before the injection before proceeding the epilation. Also, IMLA is effective in laser treatment with a wine stain, port wine stain. 66% of patients applying IMLA had reduction in mean pain compared to placebo, and 72% reduction in mean pain compared to treatment. Of course, placebo, some patients respond to placebo, that's why the percentage is a bit high, but 72%, that's all statistically significant. The p-value was very high here. 52% patient experience pain-free treatment whatsoever. So they apply IMLA, they go under the treatment, there is no pain whatsoever. That's 52%, half of the patient, they didn't need to comment about the pain at all. There is also now they use IMLA in the gynecological procedures, and there is a rationale behind this, as the mucosal lining, the female genitalia, is extremely sensitive to pain, very, very sensitive area. Speculum examination caused an anxiety and discomfort as well, and it's very difficult during the postmenopausal period, as the lower estrogen hormone caused less elasticity and atrophy, which cause more pain and discomfort for the patient. Cautery of the genital warts is also painful. Using the infiltration local anesthetic was not very practical alone, as it also very painful in this sensitive area, and also by injecting the local anesthetic, it caused bleeding. Bleeding will hinder the laser beams to penetrate the warts, which decrease the efficacy of the treatment as well. Use of local anesthetic cream is recommended by European guidelines before the infiltration of anesthesia because it's a very sensitive area. They apply IMLA cream and then they inflate the anesthesia. So in this case, patients feel less pain. IMLA was effective in gynecological procedure as well as the female genital mucosa. As we said, it's very sensitive due to decreased estrogen level at the menopause age. So adverse vaginal symptoms include dryness, loss of tone, and also hyperplasia, hypersensitivity to the pain as well might develop. At the same time, it's exacerbated by sexual intercourse or vaginal examination too. So when the doctor tries to examine the patient, it's very, very painful. Whether they put lubricant or not, it's very painful. So the European guidelines recommend to apply IMLA cream before the examination as well. This is also, again, it's a clinical study to show the efficacy of IMLA versus lubrication cream versus placebo. And also, IMLA shows 89% reduction in pain versus control in the insertion. And the dilatation was 61% reduction versus control. And extraction was 70% reduction versus control. All of them is statistically significant with a high p-value. And also in the gynecological procedure, also too, 92% of the patient used IMLA only. They did not need to add additional infiltration of local anesthetic. The 8% only needed local anesthetic injection, but also they said also it was not painful at all to inject them because the area was already numb with IMLA cream. And that's the logic behind the guideline scheme, and said we recommend local anesthetic cream to apply it before the gynecological procedure, whether it's a wart removal or examination even. IMLA was effective at protecting pain from laser removal and genital warts. It's the same idea, and it's 80% versus 12%. IMLA was 12%, the placebo was 80%, and all done using the visual analog scale, so it's some like a way to measure the pain as well. Also, the needle puncture. There is a justification why do we need the IMLA cream to numb the area before we use the needle puncture. In children, as IV cannulation in children painful and distressing. The stress may affect the ease of performing the procedure, the success rate, and the child healthcare provider relationship. As soon as they see the doctor, they want to run away. This could contribute to the child developing a phobia of the needle, and providing local anesthesia by applying topical anesthetic cream reduce anxiety and lessen the need for deeper sedation. This is a clinical study has been done for children, and needle puncture as well. And also IMLA shows 91% versus 25% placebo. IMLA help prevent the pain of taking blood compared to placebo. So that's why it's recommended now. We tell all the mothers, apply IMLA patch 1 hour before you go to the lab, or 45 minutes before you go to the lab, which will numb the area. The child won't feel the pain, won't cry, and then you don't develop any kind of phobia or trauma. And also, this is another clinical study, shows more procedures are rated as easy with IMLA compared to placebo. When they apply the cream to the children, 94% of them reported it was easy procedure versus 60% with placebo. In adults, it's the same idea. In adults, we apply the IMLA cream before also the needle puncture, because IV cannulation in adult, it's a most commonly performed invasive procedure in the hospital. Pain can increase the distress and outcome response like a vasoconstriction. When the patient is stressed, vasoconstriction happen, you lose the vein, you have to try again. Multiple trial may lead to risk of infection as well. Importance of providing pain relief is often overlooked. We don't usually do this, especially for adult. We say, well, it's not very painful, just put up with it, but we should actually consider applying topical anesthetic as well. Advantage of a non-invasive local anesthetic, like reducing pain and discomfort, reduce the adverse effect of cannulation, relieve anxiety and needle phobia, always allow procedure to be carried out more easily. Since the patient is not in pain, then we can do the procedure easily, no stress, nobody stressed. Among all of this, it's very important to use in pain control before putting the needle in a patient, as inadequate pain relief during needle puncture procedure impact the ease of the procedure, affecting the success rate, of course, of the procedure. And anxiety about future treatment, patient will run away, they don't want to do it again, deterring patient from seeking medical care. If I have to get a needle, I'm not going to do it. In this study, 22% of adults are needle phobic too. So it demonstrates that 22% of the patient in this study was needle phobic. They don't want to do the process because of they are afraid of the needle. In adult also, they apply IMLA cream versus lidocaine versus placebo to assess the efficacy in reducing the pain of venous cannulation compared to lidocaine and placebo. And of course, IMLA was superior in either arterial or venous cannulation compared to lidocaine alone or compared to placebo. And all of them was statistically significant as well. Leg ulcer. It's very, very common in diabetic patient. And nowadays, we see it a lot, and it's a very, very painful situation. As the tissue is necrotic, the physician has to clean it. If we do this without local anesthetic, it will be very painful, and also patient won't agree on the physician to continue. The physician has to stop. When this happens, the physician has to go back and try to clean it again. So it takes more number of trial. And that's what was demonstrated in the trial here, as pain often limit the effectiveness surgical debridement of leg ulcer. Patient requests stopping debridement before it's completed because they are unable to tolerate the pain, and the physician has to go back and do it again. 80% of patients with leg ulcer experience significant wound-related pain. All of them, it's a very, very painful sensation. And 67% of venous leg ulcer patients undergoing sharp debridement without any anesthesia suffer from pain up to 4 hours after the hospital visit as well. 36% of venous ulcer patients felt pain when their dressing were changed even, because it's very painful and the dressing goes inside the tissue, so it's a very painful sensation. 66% reduction in leg ulcer debridement pain compared to placebo when we applied IMLA versus placebo. 54% was placebo versus 18, and the difference was 66% relative reduction. The p-value was significant as well. Less debridement procedure, as we just talked now, the physician in this study, the physician needed 11.5 in average, of course, 11.5 debridement for a clean ulcer with IMLA to clean the ulcer completely, 11.5 visit to go and clean the dead tissue, versus more than 15 debridement for a clean ulcer with placebo. So more number of debridement, the physician has to repeat the process again, which also increase the health care cost on the patient or in the hospital or the government, whoever will pay for this. So using local anesthetic actually will save the patient the pain. The hassle will also save money and the time. Now, the section number 3 of my presentation, which we talk about the dose of IMLA, and we all know that the dose, it's a cream, so it's doesn't have to be accurately measured. However, we do have the patch, which is pre-measured already, which makes things much easier. And we'll talk about also the contraindication, pregnancy, and lactation as well. The dose, of course, we have to apply IMLA in intact skin only, no skin cut with the exception of leg ulcer. Other than this, the skin has to be intact, should not be applied to any skin cut. Minor procedure like needle puncture or needle insertion or immunization, we apply 2 grams 1 to 5 hours. This, by the way, in adult, not in kids. We apply 2 grams 1 to 5 hours in advance. And when I say 1 to 5 hours, doesn't really mean that it's going to work after 5 hours, but it will take at least half an hour to 45 minutes to work. The longer you leave it, the better result you get, because the medication will penetrate more and deeper in the skin, but last up to 5 hours, and then there's no more effect after 5 hours. It depends on the procedure has been done, where exactly the intact skin, we can do 2 grams. And also, if we do a larger area of the skin, we can go up to 60 grams at a time. But if it's a larger area, it has to be done in a hospital or facility where the overdose toxicity can be treated. A healthcare professional has to be trained to treat this. Genital mucosa, it's a very vascular sensitive area, so that's why we do not really have to apply it for a very long time. 5 to 10 minutes is enough. And we approximately apply 2 grams per each lesion as well, and we start the process 5 to 10 minutes after. Leg ulcer, we apply 1 to 2 grams each 10 square centimeter, and we apply 30 to 60 minutes, and you commence the process right after the 30 minutes. As we talked about it, leg ulcer is very, very important, which most of the time they don't use local anesthetic, which patients suffer from pain and time, and they have to go back repeatedly multiple times. In children, the dose in children, it's very similar to adult with some exception, but it goes by the age. The older the child, the more we can apply cream. We can apply approximately for skin of children for injection like immunization or regular routine blood draw. We apply 1 gram for each 10 square centimeter. Just 1 gram is enough, which is the same dose like the patches. Neonates, we can apply it also for neonates, but maximum 1 gram only. We should not apply neonates between 0 to 2 months. We cannot apply more than 1 gram. The older the child gets, we can apply more. Between 3 to 12, we apply up to 2 grams. 1 to 6 years old, we apply up to 10 grams or even 10 patches. Children between 7 to 12 years of old, we can apply up to 20 grams at a time, which is like, because IMLA is very safe and the amount to be absorbed very, very little, so there is no issue here and the dose is very safe. We can add a higher dose. The rationale of using the patches. When can we use patches versus a cream? It's the same. Patches, it's a cream, but it's a pre-measured dose, 1 gram each patch. It has the sticker itself or the occlusion itself, so it's very easy, very simple. We can just apply it 45 minutes before we need the numbing effect, either before the blood draw or before the vaccination. Also avoid, by using the patch, we avoid overdose or underdose because the dose is pre-measured already. And of course, it's very easy to apply and remove. IMLA patches doses, which is similar to what we talked about in kids before or even adults, but it's the same goes by the age. If regular intact skin, we apply 1 patch 1 to 5 hours for 1 spot only. Ages 0 to 2, we can apply only 1 patch 1 hour before. Between 3 to 12 months, we apply up to 2 patches at one time if we need 2 sites of injection, for example. Between 1 to 6 years of old, we apply 10 patches at one time. And if they are over age of 7, between 7 to 12, we apply up to 20 patches at one time. It's a very safe drug. We can apply, no issue here, and we should not be concerned about the dose. Contraindication. Of course, any hypersensitivity to any of the ingredient, it's contraindicated, either the ingredient or the excipient, or any of the same class, any medication belonging to the amide class, which is belonging to the same class like proleukin and the lidocaine. Patient with congenital idiopathic methemoglobinemia as well, that's contraindicated. And also if the process requiring to apply a large amount of IMLA over a large body area and it's done in a facility where the healthcare professional is either not trained or not equipped to treat the overdose toxicity. That's a contraindication as well. Infant require treatment with methemoglobin inducing agent and are 12 months of age or older or younger should not be applied IMLA to them as well. Preterm infant, if the child is born preterm, less than 37 gestational week, we should not apply IMLA as well. Open wound except leg ulcer, as we mentioned before, should not be applied on or near the eyes. It's not meant for the eyes at all. I don't think we need local anesthetic in the eye, plus there is no data to support anything to do with the eyes. Genital mucosa of the children, it can be only applied to genital mucosa of the adult, not the children. And that's only because it's not studied, and I don't think we'll need it for kids, but there is no data to support that, so we cannot really recommend it. A special precaution, which is not a contraindication, but we have to be careful when you use IMLA, where the patient is very ill or elderly patient also, and also the systemic effect of lidocaine might affect the patient, so we have to be careful. It will be some systemic effect in a higher dose, but not that much, but certain patients will be affected with this as well. Special care should be employed to ensure occlusive bandage patches secure to avoid accidental exposure. Especially for young kids, when you apply the cream, you don't know what are they going to do. They might take the cream, put it in their mouth, put it in their eyes. So you have to apply either the patches, which will be more secured, or to have to apply the occlusive bandage and make sure it's secure to avoid any hazard happen to the kids. Also should not be applied close to the ear at all, the middle ear, as the middle ear will be very permeable and that will increase the absorption of IMLA, which should not happen. Also, a patient with atopic dermatitis, we should lessen the amount of time and we should lessen the dose as the skin will be more permeable with atopic dermatitis as well. Patients with G6PD deficiency are more susceptible for drug-induced methemoglobinemia as well. Can be used still, but has to be with caution. Patient treated with antiarrhythmic drug, especially class 1 and class 3, like mexiletine or amiodarone, it still can use it, but ECG surveillance has to be done, and also we have to monitor the patient in case any systemic effect will happen. Also, if we are giving patient infiltration anesthesia, same class like lidocaine, proleukin, we have to count this dose like with us too, because if we give IMLA plus the infiltration, that might increase the dose. So that's another special precaution too. Use of IMLA in pregnancy or lactation. Of course, till now, there is no reported cases, any teratogenicity or any malformation using IMLA in pregnant women. However, there is no clinical study to support you can say yes or no. So using IMLA during pregnancy has to be with precaution, and we have to weigh the risk and against the benefit. But so far, there is no reported cases at all. Lactation, lidocaine and most probably also prilocaine will be excreted in the mother milk with a small quantity, very small amount, but that's not clinically significant. The children affected with this has no reported any side effect at all. So still we can use it in lactation as well, even though it was secreted in the mother milk, but it's just one of the precautions. It's not a contraindication.